All right, we'll get started. Welcome everyone to Cardiology Grand Rounds. It's a real pleasure to have this truly interdisciplinary and interactive session. We'll be hearing from Dr. Marie-France Poulin, who is the Associate Director of the Structural Heart Clinical Services, as well as the Associate Director of the Interventional Cardiology Fellowship Program. She's an Assistant Professor of Medicine at Harvard Medical School. We'll also be hearing from Dr. Al Buxton, who is an esteemed electrophysiologist in our division for many years, as well as the Ben Heim Josephson Professor of Medicine at Harvard Medical School. So thank you for joining us for this session.
As Dr. Asnani said, this is going to be a tag team. And before Dr. Poulin speaks, I just want to emphasize that what you're going to see represents an ongoing and intimate collaboration between the electrophysiology group and the interventional cardiology group, with multiple people contributing and responsible for this work. So, Marie-France.
Well, thank you for allowing me to be part of this. This is a great project and had certainly a lot of, it was great working with you for this. Okay. I guess. So a little bit about aortic stenosis. So it's actually a fairly common condition. In patients in the United States, age 65, it actually reaches a prevalence of about 5%. And in an Icelandic population, slightly lower, but similar, 4.3% in patient age 70 years old. So TAVR has undergone a really crazy approval path in the US and a crazy journey since its approval in 2011 for patients who were prohibitive surgical risk. The volume has kept growing through the years until in 2019, their curves actually crossed. So more TAVRs in the US, there were more TAVR cases done than surgical cases, and the curves have continued to grow over the years. That being said, the cases of pacemaker has actually, of patients who didn't have a pacemaker, so new pacemaker post-TAVR, has slowly decreased and stabilized around 8 to 9% in the US. And that's due to lower patients undergoing TAVR, but also optimization of the implant techniques. Oh, that's you. Yeah.
So one of the frustrating limiting factors in patients undergoing transcatheter valve replacement has been a fairly high incidence, as you see here, of patients requiring permanent pacemaker implant. And of the data that have been published, the mechanisms are not fully clarified. Most of the studies using, and there are several smaller studies using intracardiac electrophysiologic measures, report variable clinical utility from performing His bundle recordings during the TAVR. The published studies have attributed AV block primarily to disturbances in His bundle function. They've observed some changes in AV nodal function, but the contribution of the AV node to block in these patients is not clear. And indications for pacing in the absence of complete heart block or Mobitz 2 block are not clear. Another area that's received a lot of attention in the literature is the onset and the prognostic significance of patients that develop new left bundle branch block during the TAVR procedure. People have been very concerned about that, even when these patients have not exhibited AV block. And another frustrating and limiting factor is the fact that in all the series, a significant number of patients have developed heart block only after discharge from the hospital. And a lot of work has been aimed at trying to identify people at risk for that problem, obviously. Why do patients who are undergoing TAVR have develop these conduction problems. And you got to understand the anatomy. So on the left here is a picture showing where the His bundle, the common, yes, the pointer showing, the common bundle of His, or the AV bundle, is situated in most people in the membranous septum. This is the septal leaflet of the tricuspid valve. This is the membranous septum, the aortic root you see, and the muscular interventricular septum. And the His bundle traverses this membranous septum, which, as you will see, varies quite a bit in its anatomy. On the right, you see a transilluminated section with the left ventricle opened, showing the location of the membranous septum right below the right and, in some people, the non-coronary cusps, where the catheter prosthesis would be placed. In this picture here on the left, you can see an opened right atrial view, and you can see the location of the AV node in what is called the triangle of Koch over here. And the AV node, leads right into the His bundle sitting in the membranous septum. This dissection has unroofed the endothelium of the right ventricle, and you can see the right bundle progressing on the right side of the right ventricle. The tricuspid valve leaflet would insert along this dotted blue line here. In these micrographs, one of the issues that we know is that there's a lot of variability in the conduction system anatomy. So, for example, the AV bundle, the common AV bundle, the bundle of His, in some people is situated towards the right side when it enters the muscular septum from the membranous septum over here. In other people, the AV bundle sits more on the left side of the septum after it exits the membranous septum. In addition, the AV node, which has been considered not to be at risk for injury, let's say, during the TAVR procedure, also has variable anatomy that can impact this. So in some people, although the common anatomy, you see here these fluoroscopic right anterior oblique images showing a catheter in the coronary sinus, catheters recording a maximal His position over here. In some people, in the lower right, the AV node occupies what is felt to be the typical usual position, fairly low down in the triangle of Koch over here. In other people, though, the compact node can be situated quite high and would be at more risk, in theory, to conduction abnormalities when either a surgical or transcatheter aortic valve is placed. And to show the relative lack of understanding, this is a quote from the recent ACC expert consensus panel on management of conduction disturbances in patients undergoing TAVR. And you see, they say that drugs that affect the AV node should not be a problem, which is true during TAVR, because the aortic valve lies near the bundle of His and not the AV node. So there's a lot that's not well understood. The final anatomic consideration is to understand the left bundle. Now, the left bundle is a very different structure than the right bundle. The right bundle, as you saw in the earlier picture, is a thin strand-like structure going along the right side of the right ventricular septum. The left bundle is a broad band in this picture by this classic work by a Japanese anatomist, Tarawa, who was working in Germany and did the seminal work on the anatomy of the conduction system. You see that the left bundle is a broad band-like structure situated in most people right below the right coronary cusp. Most people that have left bundle branch block under normal circumstances, it is an intra-His lesion and not disease in the left bundle branch itself. A stained view of a bovine dissection, again, shows this broad band-like nature of the left bundle situated right below the right coronary cusp. There's actually one that we've been able to find, one case report of a patient that died suddenly shortly after undergoing TAVR. And what's interesting is this patient had the author's report, an uneventful procedure aside from developing complete heart block. The patient received a permanent pacemaker shortly thereafter, was discharged, and 3 days post-procedure, they suddenly arrested and they died. They were unable to resuscitate the patient. At autopsy, the aortic prosthesis appeared normal. When the valve was removed, not surprisingly, there were areas of hemorrhage and calcium seen. On histologic exam, on the left, you see a low power view, and this pink structure right here is the bundle of His. This is an amyloid deposit. This here is normal myofibrils adjacent to the His bundle. On this high power view, you see hemorrhage adjacent to the His bundle that may, in fact, be responsible for heart block. The mechanisms we think that are responsible for heart block in these people are multiple, and I don't think it's one specific condition. This case of this patient dying also points out the fact that pacemakers that we implant for these patients aren't necessarily benign. This patient probably died because the right ventricular pacing lead perforated the RV free wall, causing tamponade. So it's easy to say, well, if the patient develops heart block or high-grade AV block, just implant a pacemaker. But pacemakers are not risk-free. And so we try and make sure that the patients that we implant pacemakers after these procedures really are going to benefit from them. So at this point, I want to turn this over back to Dr. Poulin.
Thank you, Dr. Buxton. So with this, we wanted to, reiterate that patients who undergo a TAVR procedure are all anatomically different and sometimes quite different. Some of them have more calcium than others. The distribution of calcium can significantly vary for these. We see bicuspid, tricuspid valves. Some annulus are very small. Some of them are more large, ovaloid looking. They can have significant chunk of calcium protruding. The distribution of calcium in the aorta can also vary. A lot of them have STJ calcifications that can be significant. Coronary height can be very high or can be pretty much zero, as shown over here. The membranous septum length that Al talked about can be very long in some patients, but can also be pretty much non-existent in others. And when we talk about doing valves and valves for TAVR, again, some patients have plenty of room to put a new prosthesis, but others pretty much it occupies the whole sinuses. So before we talk about the results of the whole cohort, I just want to briefly talk about the pilot study that we did and published in JACC Interventions. So we looked at the feasibility and safety of having TAVR operators, so cardiac surgeons and interventional cardiologists, so people who don't have any EP training, doing the EP study during a TAVR procedure. So we took the first 50 patients and all comers, valve and valves, tricuspid, bicuspid valves were included. And we used one of these catheters, multipolar electrode catheters. And this is the one that we ended up using more often because it was deflectable. So it was a little bit easier to put in the exact position we wanted to, and it had more electrodes. So it allowed us to record sometimes the His as we were continuing the procedure. So this is what it looks like on fluoro. And I've added the illustration of the tricuspid valve and identified the non-coronary cusp. So initially the pacing catheter or the electrode catheter was advanced into the right atrium onto the free wall. And then Al would get some measurements, including the Wenke-Back cycle length, but he's going to go over all the measurements he got in a few minutes. And then once that was done, we would move the catheter to the His. That was actually the trickiest part to do, and try and identify the proximal His so that we could have great measurements. But it was typically underneath the non-coronary cusp on fluoro, just above the tricuspid valve. And then once the measurements were recorded, we would advance it into the RV for rapid pacing during the valve deployment. What we found is that we had a more stable position if the catheter was actually in the mid wall, as opposed to for balloon tip pacing catheter, we would typically just advance it at the tip. But for this, we had actually a more stable position if it was mid septum, and also it allowed us with the distal electrodes to record what was going on with the His. After the valve deployment, this is kind of what it looked like. So typically under the tip of the valve, that's typically where the His would be. So we just pull back the catheter and do some more recording, and finally put it also in the RA for more recordings to see if there was any changes in the intervals post valve deployment. So what we found is that after about 5 cases per operator, and breaking out the cases, the EP study in parts like this, it added minimal time to the TAVR procedure. We were safe. We were successful into getting adequate electrocardiograms in all cases, and only 2 complications, 2 new cases of AFib that we attributed to asynchronous pacing, which we later on changed in our protocol. There was 1 case where the patient was getting unstable. We couldn't get a stable position in the RV. We put a balloon tip catheter for that part, and then put back the electrode catheter for the final measurements. And I'll let Al talk about the rest of the trial. Thank you, Dr.
So in the published literature, a number of factors have been found to correlate with risk of AV block in these patients. The most consistent is a pre-existing right bundle branch block, as you might imagine. But other ECG markers, such as a beginning with a prolonged PR interval, in some studies correlate with risk. Left bundle branch block, either pre-existing or new, has been an inconsistent risk factor. Anatomic factors, several studies suggest that patients with shorter lengths of the membranous septum are at higher risk for heart block. Valvular calcium, its location, the degree of it has been correlated in some studies. And then procedural factors, including predilation before the valve position, the implant depth, and valve oversizing, which is sometimes necessary depending on the patient's anatomy and the specific valve shown. So we undertook a study because we wanted to, whenever possible, record continuous His bundle measures to find out where during the procedure would heart block occur, and was the AV node ever involved? How often was it? And to try and understand better these mechanisms in order to come up with a better schema for identifying patients that would benefit from permanent pacemaking, either during the initial TAVR hospitalization and hopefully minimizing the number of patients that would develop late block. So we performed a prospective study of 399 consecutive patients here from middle of 2021 to the beginning of 2023. As you saw from Marie-France's presentation, we initially placed the catheter in the right atrium. We paced incrementally for brief periods because you can't pace these patients like we normally would do to assess AV conduction in the EP lab. You can't pace patients with critical AS for prolonged periods at rapid rates. So we did brief periods of atrial pacing to AV block. Then we would advance the catheter to the His bundle position, record as proximal a His bundle position as possible. And then whenever possible, we would advance it into the right ventricle because you understand that rapid pacing is necessary in the ventricle during the valve deployment in order to stop cardiac motion and safely deploy the valve. And whenever possible, by using this decapolar catheter, we tried to achieve a stable pacing position while also obtaining stable measurements of the His bundle recordings. So the catheters were placed by the structural team. An electrophysiologist monitored the ECG and intracardiac electrograms continuously throughout the procedure. And patients after the procedure, The typical duration of hospitalization here is 1 day, unless there are other issues after the catheterization. Patients that developed new conduction abnormalities or that had pre-existing right bundle branch block were discharged with a 2-week ambulatory monitor. We looked at a number of anatomic variables in order to determine, could we identify key factors that might make patients at higher risk for heart block. We looked at a number of procedural variables that some people have looked at, others have not in prior publications, and as well as the ECG and the electrophysiologic measures. So as you could see, here is the entire population of 399 patients. It's fairly typical when you look at other reports of patients undergoing TAVR with a fairly advanced age, roughly equal numbers of men and women, and fairly frequent other cardiovascular and systemic diseases. A small number with pre-existing persistent atrial fibrillation. About a quarter had a prolonged PR interval to begin with. 5% had left bundle branch block. 12% had right bundle branch block before the procedure. One of the limitations of this study is the majority of the prostheses used here are the SAPIEN 3 prostheses. So it is possible that our results aren't directly applicable to other types of valve prostheses. We also included 36 patients that underwent valve-in-valve procedures. In other words, these were people with pre-existing surgical or conceivably catheter-placed prostheses, aortic prostheses. These are thought to be at lower risk for heart block since you already have a structure, a mechanical prosthesis in there, but we weren't sure, and so we included these patients. Now, for those of you that aren't familiar with performing His bundle measurements, I show this illustration here so you can be oriented to a lot of the electrophysiologic data we talk about. On the top here, you see 3 surface ECG leads with a simultaneous recorded His bundle. And so when the His bundle catheter is placed across typically the superior aspect of the tricuspid annulus, we can record an atrial deflection from the surrounding atrial myocardium. Then there's a isoelectric, relatively silent period that represents conduction time through the AV node. We don't directly record AV nodal activity using these techniques. Then we see a rapid sharp spike that represents activation of the His bundle. Then again, there's a brief period of apparent no activity, isoelectric, and then we have ventricular activation. And the intervals that are measured are the AH interval, which is the time from the onset of the atrial deflection to the onset of the His, and is the surrogate for AV nodal conduction time. Normal value for that is between 60 and 125 milliseconds. And then we measure the HV interval, which is the time from the onset of the His activation to the first onset, either in the surface or an intracardiac lead of ventricular activation. And the normal range for that is 35 to 55 milliseconds. You notice that there's a much larger range of normality for conduction through the AV node than the His bundle. And there are several reasons for that. One, autonomic tone has much more influence on AV nodal function than His bundle function, although they're both affected by it. Secondly, the AV nodal cells have much more capability, although they conduct slower than the His bundle and the bundle branches, they can prolong conduction to a great degree, 3 to 4 times over the upper limits of normal, whereas the His bundle has very little capacity to prolong conduction. And if you double conduction time in the HV interval, so if under normal circumstances, if you see an HV interval of 90 milliseconds, that's likely to be a patient who's had syncope due to paroxysmal AV block, or is at high risk for going on to persistent AV block. So there's a fundamental difference in the physiology of these tissues. So here's what we found. The average AH at the beginning of the procedure was 99 milliseconds, well within normal limits. At the end, there was a slight increase, still within normal limits. The Winkie-Bach cycle length, that is, when we paced the atrium, on average at the beginning was 444 milliseconds, which is well within the normal range for people. At the end of the procedure, there was a statistically significant, although one might regard this as clinically insignificant, but there is a significant, and this has been seen in other studies, increase in the cycle length. In other words, a decrease in the heart rate at which AV Winkie-Bach occurs. With regard to the HV interval, the baseline HV interval average was basically 60 milliseconds, which is just slightly above the upper normal limits of 55 milliseconds. At the end, there was an average of 10 milliseconds increase into a fairly abnormal range of HV intervals for the entire study population. So with regard to conduction abnormalities, one patient actually had not previously recognized, before any catheters were placed, had intermittent 2-to-1 AV conduction block when she entered the lab. 60 patients developed varying degrees of AV conduction abnormalities, from just prolonged PR interval, Winkie-Bach, Mobitz 2 block, but 51 patients developed complete heart block. And in 26, the AV block was complete block, that is, of the 51, and in a couple of cases, Mobitz 2 block persisted to the end of the procedure. The patients with transient AV block, it lasted a median of 1 minute and a mean of 7 minutes. And in a couple of patients, it took a couple of hours after the procedure to resolve. As a result of the either complete heart block or Mobitz 2 block, we ended up implanting 20 permanent pacemakers, either at the end of the TAVR procedure or during that initial hospitalization, which was a median of 1 day and a range of 1 to 10 days. The prolonged hospitalizations were primarily due to non-cardiac, non-valve, or EP issues. However, 20 patients developed heart block or Mobitz 2 after discharge. So you see a total of 40 patients, or 10% of the patients in this series, developed either complete heart block or Mobitz 2 block, necessitating implantation of a permanent pacemaker. For those that were discharged and then developed heart block, the heart block occurred a median of 4 days after the discharge, with a range as you see here. Mortality was 5 patients, 1 periprocedural mortality that was not related to directly to the valve or to the electrophysiologic study. And there were 4 late deaths with a median of 14 months after the procedure. None of them, as best we can determine, were sudden deaths. Yes. These 20, the late blood. I'll get to that later. That's obvious of interest and concern. Although the majority of the patients with AV block developed intra or infra-His block, there were 8 patients in which we demonstrated very clearly changes in AV nodal conduction. It was transient during the TAVR procedure in 5 cases, including complete heart block. But after discharge, 3 patients developed complete block in the AV node. And the baseline AH intervals you see in one of the patients, he started out with markedly prolonged AV nodal conduction. But the other 2 had perfectly normal baseline measures here. The complete heart block occurred 1 day after the procedure, 3 and 5 days. And of interest, although 1 patient was in persistent atrial fibrillation, so we could not measure a PR or AH interval, 4 out of the other 7 had baseline PRs that were moderately, at least, prolonged. To show you an example of what we're looking at here, here is a 79-year-old woman who came into the lab in sinus rhythm with a slightly prolonged AH interval, normal HV interval. She Winkie-Bocked at a normal rate. And here you see her baseline tracing with A during the P wave, a hiss, and a normal HV interval, normal QRS. She developed heart block that lasted 11 minutes during the procedure. And this block, you can see here, A's not followed by the hiss. So this is block in the AV node. 3 days after her TAVR, as I said, that heart block lasted only 11 minutes. 3 days after her TAVR, her ECG was back to normal. However, she then came back, and this is a second case of another 79-year-old woman who started out with a normal AH, slightly prolonged HV interval, normal Winkie-Bock. She had normal intracardiac measurements in the baseline state, as you see here, A, HV, no AV block. In this case, at the end of the procedure, her AH was slightly prolonged. The HV was unchanged. There was an increase in the Winkie-Bock cycling or a decrease in the heart rate at which Winkie-Bock occurred. 3 days after, on her monitor, she called with complaints of lightheadedness, and she was seen to be having episodes of paroxysmal high-grade AV block. We studied her in the lab 1 day later, and we found when she came to the lab, she had a new left bundle that ultimately resolved. She was conducting initially 1-to-1 with a moderately long AH interval. And then we saw spontaneous episodes of Winkie-Bock in the AV node, AH, a longer H, a no H. So she had typical AV nodal Winkie-Bock that didn't appear until 3 days after the procedure. 1 month later, we implanted a pacemaker because of her symptoms associated with high-grade AV block. 1 month later, she was pacing only 0.5%. And you can see here her ECG, although there are pacer spikes, they're fusing with normal QRSs. One of the difficulties in analyzing published results is none of the papers describe how were pacemakers programmed. And the need for pacing late after implantation of a pacemaker is very much unclear. And that's because, as you can see, after this lady followed up later at another cardiology office, the programming of the pacemaker was changed. They shortened the AV delay in the pacemaker, making it more likely for her to pace in follow-up. But I think while it's possible she needed it, if you reprogram the pacemaker and you lengthen the AV delay to allow spontaneous conduction, it's very likely that a lot of these people would not be pacing nearly the amount that they may appear to be. We saw some very interesting and unanticipated behavior in the His bundle during the procedure in 9 patients. So here's a 79-year-old man who came in with a normal H interval, a normal HV interval, right bundle branch block. Following the valve deployment, he went into complete heart block, and this block you can see is in the His or below the His. The AH interval remains normal in this case, and he still has a right bundle branch block escape. So this is probably block within the His bundle itself. We studied him because his conduction, he was left with a temporary pacemaker. We studied him 1 day later, and now you can see on the surface, he's showing Winkie-Bock, typical Winkie-Bock with a progressively longer PR and then a blocked P wave. The intracardiac recordings show that this Winkie-Bock, in contrast to the usual situation where Winkie-Bock occurs in the AV node, he was exhibiting Winkie-Bock within the His bundle. Here's a proximal His recording. These are probably more distal His recordings with progressive prolongation of conduction, the His bundle, and then block within the His bundle. 2 weeks later, he was still mostly pacemaker dependent, pacing 75%. 1 month later, he was pacing only 21%, and his ECG had returned to the baseline state. And when we interrogated the pacemaker 7 months later, there was minimal or no RV pacing need. Another case of rather bizarre behavior in the infranodal structures, a 79-year-old woman came in with a baseline ECG showing a prolonged PR and right bundle branch block. In the lab, her AH interval was moderately prolonged. Her HV is moderately prolonged. She Wenke box at a relatively long cycle length, just under 120 beats per minute. And here you see her intracardiac recordings with a relatively long conduction time prolonged through the AV node, and a slightly long HV interval. Immediately after the valve was deployed, she develops no change in the AH interval, but the HV interval of over 300 milliseconds is unbelievable. We would not normally think that this kind of HV interval was compatible with intact conduction. The conduction improved. She never developed complete heart block, although she had episodes of 2-to-1 AV block. And we studied her 12 days later. And amazingly, the HV interval that had been 300 milliseconds in the lab after the valve deployment had returned to baseline. So when we look at the overall global results, of the 40 patients that developed heart block during the procedure or after the procedure, the major risk factor was pre-existing right bundle branch block. About 1/5 of those patients developed heart block and they received permanent pacemakers. Left bundle branch block at baseline or new left bundle during or after the procedure did not correlate with risk of heart block. A markedly prolonged PR interval at the end of the TAVR procedure did have pretty good correlation with subsequent heart block. When we look at the people that developed heart block after discharge, which is a major concern, those are the patients we want to identify and prevent this kind of thing from happening if possible. Right bundle branch block at baseline did not prove to be a predictor, nor did left bundle branch block at baseline or after the procedure. But the post-PR prolongation of the post-TAVR PR prolongation to a marked degree still did correlate with risk. Those are the ECG predictors. The electrophysiologic predictors proved to be most constant. And we looked at varying degrees of prolongation of AV nodal conduction and infranodal conduction, because in the literature, people have advocated implanting pacemakers in anyone after TAVR who had an HV more than 55 milliseconds, the upper limits of normal. Other publications have advocated implanting pacemakers for people with HV intervals of 70 milliseconds or more. So we found that patients at the end of the procedure who had HVs greater than or equal to 70 were at minimal risk, but more severe degrees of prolongation at the end of the procedure in the HV interval did correlate pretty well with risk. Transient heart block did correlate with risk, as did the duration of the heart block. And the Wenke box cycle length at the end of the procedure also correlated. Predictors specifically of late heart block after discharge, and I would say you need to understand that also in contrast to a number of published studies, we did not let implantation of a pacemaker be influenced by any of the EP measurements we made. the determination for need of a permanent pacemaker was based solely on spontaneous, persistent, complete heart block, or episodic high-grade AV block, or 2-to-1 Mobitz 2 type block. The electrophysiologic correlates with late heart block included the marked prolongation in the HV interval, again, of greater than 80 or greater than 90. You can see relatively higher risk, obviously, with more severe degrees of prolongation of conduction, but also prolongation of AV nodal function correlated with late heart block. And it's really not clear. This is a mystery to us because we know that we could demonstrate consistent prolongation of AV nodal conduction. We saw, though, very few instances of block in the AV node. So why this should happen is really not clear. The issue of left bundle branch block, as we said earlier, has been raised in the literature multiple times. And what we found was that the pre-existing left bundle as a risk for heart block after discharge was not very useful. The HV interval in these patients with new left bundle branch block wasn't predictive at lesser degrees, but as with the entire group, more marked degrees of HV prolongation at the end of the procedure did correlate with the risk for subsequent heart block. Anatomic variables didn't make a huge contribution. We restricted this analysis to the patients receiving the sapien valves, which were the majority, as you saw, and because a lot of the measurements are evidently not relevant to patients that receive the self-expanding valves, the core valve or the evolute valve. It did turn out, as others have noticed, that if the implant depth of the valve is deeper, you're more likely to affect conduction. Predilation had a modest predictive correlation with subsequent heart block after discharge. So we got a lot of nice p-values, and they're great for publishing, but unfortunately, there are limitations to applying these to practice. And I show you that here. When we take the three most prominent measures of conduction abnormalities, a markedly prolonged HV interval, the markedly prolonged PR interval at the end of the procedure, and a lower rate at which Wenckebach occurs when we paste at the end of procedure, the risk for late heart block, you have impressive odds ratios, impressive p-values. The sensitivity of any of these is not great, nor is the specificity. The positive predictive value, only 10 to 20% of patients who had any one of these abnormal went on to complete heart block or Mobitz 2. Fortunately, though, there is a glimmer of hope. The negative predictive value is pretty good. If you don't have any of these factors, then your chance of developing late heart block is pretty small, still not zero. Another way we looked at this was to say how many of these people that developed late heart block had abnormalities at any point in their measures. And you can see that the mean PR interval of these people was slightly prolonged before anything was done. It increased, but on the 1 day post-TAVR ECG, it was basically back to the same level. And it was normal in 6 of the 20 that subsequently developed heart block. Likewise, the QRS at mean level was normal. It increased after the valve, but was basically back to normal 1 day later. And 11 of these 20 with late heart block had normal QRSs 1 day after the valve had been implanted. AH intervals, mean levels were at the upper levels of normal. Wenckebach was normal to begin with. It was slightly longer, in other words, at a lower rate after. The HV interval started out normal, slightly prolonged to begin with, and then it did increase markedly on average. So again, the intracardiac electrophysiologic measures seem like they may be useful. So in summary, Alterations in both AV node and His bundle function correlate with risk of heart block accompanying TAVR. Marked delay or decremental conduction in the His after TAVR is not necessarily permanent. His bundle recordings during the TAVR may have utility for predicting risk for delayed AV block. And in this series of pre-existing patients with pre-existing right bundle branch block, it correlated with risk for heart block peri-procedural, but not delayed complete heart block. And new left bundle branch block, in contrast to some reports in the literature, was not predictive. ECGs in the patients early after a TAVR that show a markedly prolonged PR interval or Winkie-Bach may not represent the usual case of delay in the AV node, but it may be infranodal delay. And in this series of predominantly sapien valves, anatomic and procedural variables seem to make minor contributions to the risk of delayed complete heart block. And finally, you can teach old dogs new tricks. Interventional cardiologists can perform His bundle electrograms. It remains to be seen whether they can interpret them correctly. Finally, there's a question that comes up. Why do we see in some of these patients this bizarre behavior of markedly prolonged His bundle function that is not what we're used to seeing? And a large motivation for undertaking this study is to try and understand the mechanisms underlying these abnormalities. And one possibility to understand it, we need to go back several years to a very nice animal study done in Switzerland, in which it was shown that if you take normal myocardium, working myofibrils, or Purkinje tissue, and you partially depolarize it, in the case here, it was by infusing potassium to lower the extracellular potential, you can produce AV nodal type behavior. You can see slowing of conduction from partially depolarized His Purkinje tissue, and you can see decremental Winkie-Bach type behavior. And so how can we tie that in with what's done during the TAVR? Well, when the interventionalists place a prosthesis, there's a sudden pressure on the aortic root and these tissues. And we know that if you suddenly expand heart muscle, you stretch it, and you will activate stretch-activated membrane channels. These are fairly nonspecific channels. They conduct sodium, potassium. They will cause partial depolarization, activation of these channels. And that could be an explanation why we see these marked abnormalities that usually seem to reverse over the next few days. It doesn't seem likely that if somebody has a rock of calcium that's being displaced into the His bundle by the valve prosthesis, that's going to resolve very quickly. So it's an interesting, it's unproven. We need to do further work to understand this better, but it's an interesting hypothesis among others. Finally, we need to acknowledge the structural cardiology team, especially B. Ultimo and Kim Gabon, the research network under Jen Kaufman and her team, the structural cardiology fellows who consented patients and helped with the care of them, the cath lab nurses and technicians, Mike Carlosi and Bill Burke in the EP lab who helped us with the equipment, and our DSMB with Bobby Ye, Eli, and Dan Kramer. So thank you, and we can take questions. Yeah, Joe.
Great. Interested in the patients, the 40 patients who got pacemakers, you obviously now have a wealth of information in the pacemaker. And you showed that some of these people with the appropriate delay, weeks, months later, on pacing.
Yeah.
What was the whole cohort? Like say 3 months, 6 months, how many of them were pacing?
Of all, I'll repeat the question. Yes.
You were to give them the appropriate delay.
Yes.
What percent still pacing?
So the question is, what's the need, what's the degree of persistent pacing in patients that received permanent pacemakers? And a corollary to that needs to be addressed is what percent of patients went on after the 1 month follow-up, which is recognized to be the period of highest risk, to then develop heart block. I can't answer that completely because we don't have 1 year complete follow-up as yet. And we also don't have, unfortunately, a lot of these patients come from afar, like down at the Cape, and they refuse to come back for follow-up. We have reliable 1 month follow-up, and about a third of the patients at 1 month are pacing minimally, less than 0.1%. But a significant number are still pacing 99%. But again, we don't have control over the pacing parameters in many of these patients. And so I can't state for sure how many really need the persistent pacing. Of the patients that didn't develop heart block and we have follow-up, we know of one patient 8 months later who developed heart block. This was a man who was in persistent atrial fibrillation with relatively slow rates, but asymptomatic. And then 8 months later, he presented to the CDAC with dizziness. He was in complete heart block, and he received a pacemaker. And I think that's probably just natural history of progression of underlying disease and not related to the procedure. And we've not identified anybody else yet of these 399 that have developed late heart block. Mike?
Yeah, this is very attractive. It's still down. It's certainly actionable if people are proposing putting pacemakers at these arbitrary HV intervals where you've shown positive values.
Yeah, you'd be implanting an awful lot of unnecessary pacemakers.
So then if you take it to a place like here where we're therefore judicious about putting pacemakers, use a normal HV interval, say somebody has transient heart block, puts in variant implants, then would you use the HV interval to say, all right, this one's normal, negative predictive value, if we're needing something's good, we can definitely wait for conversely a markedly abnormal HV interval that somebody had 3 months of complete heart block in case to put a pacemaker.
I think we have to pay attention to the data. And what we've seen is that people, certainly with HVs of 90 or more, and at the end of the procedure, that they have relatively high risk, although it's still way less than 50%, more like 20%. But given the fact that we'd like to see patients not fainting after they go home. And as an aside, I didn't mention, of the 20 patients that were discharged and then developed complete heart block, only two had syncope. All the others, it was picked up asymptomatic or with minimal symptoms like lightheadedness on the monitor. So I think at this point, a key factor in the management of these people is monitoring. And we were using these mobile cardiac telemetries, not a standard Holter, a Zeo patch monitor, so that we could give immediate feedback to these patients. And of note, we went through, I think, 3 different purveyors of these monitors to get a service that would provide reliable, rapid feedback to us. Eli? We'll convert you yet.
See what's going when you show one slide where there's a clear amyloid deposition, although there's a lot of older people that have amyloid deposition.
Sure.
It seems like there's a subgroup of patients who develop severe conduction abnormalities and we don't completely understand, although we're well in the way of understanding, we don't completely understand how to predict this based on anatomy or electricity. What is the role of additional imaging for TAVR to maybe tease out amyloidosis or other structural disease that may apply the model.
The question for those not in attendance is, what's the potential role of coexistent amyloid cardiac disease to some of these conduction abnormalities? And what is the potential role for other types of imaging? And for that, I would turn the question to Dr. Poulin.
I'm not sure that we really know. I mean, I'm sure it contributes somehow to the condition, to some of these heart blocks. I'm not sure there's great imaging tools to really, you know.
I guess I don't ask this. Besides that, or something that. Evidence of amyloidosis. Image them appropriately, but they're not all common.
Yeah, they could be that subset. I don't know if there's any good way for us to know, you know, if these were these patients. I don't know how we could image the HIS really to know if there's amyloid in there, but yeah. Of the HIS?
It's not in our job description. Jason?
Well, part of what made it so challenging, right, is this idea of like micro hemorrhage, or if there's a, you don't know.
Sure.
You deploy it, you get these numbers, but then bleeding happens, the bleeding stops, and the bleeding happens, but the bleeding stops, and bleeding resorbs, and because I don't know if this was looked at, and a lot of patients were on the same drugs, but whatever, if well, that's changing, you know, platelet counts, platelet functions. I mean, I'm just thinking, is there a bleeding? So there'd be a way we could try to minimize bleeding risk moving forward.
We could look into that. That's a great point. I guess to repeat the question. So is there, you know, have we looked into either drugs that the patients were on or their platelet counts or other, you know, related or that factors that could be predictive of bleeding into the HIS from the valve deployment? So we haven't looked at that, but that's something interesting that we could look at. Yeah. Thank you.
Jane.
I'd like to understand correctly that part of some of the complete heart block that resulted in being AV nodal seems surprising. In that
Yes.
case, would you rethink sort of what's in the guidelines? Would you think about AV block needs?
So the question is, AV nodal disease, what degree of contribution does it make? And could drugs, you mean, altering or withholding people taking AV nodal blockers, would that have a beneficial effect? And there's one study that I'm aware of that looked at holding it. There was no risk, no difference in the outcomes in patients in whom AV nodal blockers were held. I'm not sure that that would make a huge difference globally, since AV nodal, what's important here is to recognize that some people's anatomy, I think, predisposes them to impairment of AV nodal function, but having a beta blocker or a calcium channel blocker on board, I'm not sure how that's going to affect if a lot of this is mechanical type influence. If there is, and the people that develop the Winky-Bach type behavior below the node, that's probably not going to be significantly affected by beta blockers. If the tissue becomes partially depolarized, calcium channel blockers could have an adverse effect there. But it's an interesting question. What it means, I think, is we've not previously in this analysis looked at what drugs were people taking. And we'll do that and see, is there any correlation there that we could come up with?
We were holding their beta blockers. So we're still holding it. Yeah, pre-procedure as part of our routine protocol. But so I guess we could still look at it, but I would presume it would be out of their system by the procedure time.
Yeah, calcium channel blockers might be make more of a contribution to some of these. Kazi?
Thank you. This was, again, first time I've thought about aging in a long time. I had a couple of questions. One was, you may have done this already, but you presented a series of one-way analysis. When you put them together, does the statistical performance improve? In particular, is there anything that the intracardiac data are adding to a combination of clinical?
Yeah.
And the second related question was, how do you think that the economic value of this procedure? Is it better to just put a patch on everybody and then let them go rather than trying to train interventional cardiologists to do predicting this?
Oh, I think we still have a lot more. I'm sorry. The questions are, should we put a monitor on everyone? That would be a lot, very expensive and relatively low yield. And I'm seeing signs from our Holter lab technicians that we don't have the resources to do this. So I think we still have a lot more to do. And I think that our interventional cardiologists can, especially in collaboration with the electrophysiology group, can make a number of these recordings and shed more light on this subject. With regard to your question about, you're absolutely right. I presented a bunch of univariate analyses, and the reason for that is there's a little bit more of the anatomic data that we've not completed analysis of, especially the length of the membranous septum. We've been waiting till we have all the measurements completed and verified of the anatomy before we compile multivariable models. One of the limitations, if you look at this slide here, we said to ourselves, what if we combine, let's say, a prolonged PR and a lower rate at which Wenckebach occurs? The problem is we're dealing with very small numbers. We're talking about 4 patients that have both of those. So, even though this is the largest prospective study with intracardiac recordings to date, it's still, the numbers are relatively small. We had originally proposed studying 400 patients, and we thought we had studied 400. And when we analyzed the data, we found that one patient had been entered into the database twice. So we only analyzed, in fact, studied 399 patients. And in addition, there were 10 patients in whom we didn't achieve any decent HIS recordings. So we've just been approved by the IRB to study another 11 patients. And maybe we'll have some more events that'll help the p-values, help some of this understanding. But it's not the last word, certainly. But it helps, I think. Yes, Reza. Yeah. It didn't correlate. We looked at people who developed new left bundle that resolved by the end of the procedure, that resolved the next day. None of those variants contributed anything. Okay, well, thank you.